Good morning, everyone. Respected Emeritus Chairperson, sir, Honorable Vice Chancellor, sir, Honorable Pro Vice Chancellor, sir, respected Medical Superintendent, sir, senior faculty, and dear colleagues. I, Dr. Manish Singhal, Professor in Plastic Surgery Department. Today, we are here with a case in the combined clinical round of an 8-month-old child with a rare facial cleft. Our department comprises of a team of faculty members, 6 in number, 3 professors, 3 associate professors, 2 in oncoplastic surgery. The department started in 2013 and the MCH course started in 2016 with 1 seat. Presently we have 4 seats per year with an average number of 600 OPD cases per month, and we are operating approximately 130 cases per month. We have multiple publications in national and international journals. All the subspecialties in the plastic surgery department are well developed. In the last 1.5 years, we have operated about 15 cases of craniofacial surgery, and along with hand burns, brachial plexus, microvascular surgery, and other routine plastic surgeries. With media coverage for our craniofacial cases, our previously operated cases. Now, I hand over to Dr. Supriya, our MCH resident, to present the case.
Good morning and a warm welcome everyone. Emeritus Chairperson, sir, Honorable Vice Chancellor, sir, senior faculty members, and my dear colleagues. I am Dr. Supriya, second year MCH resident from the Department of Plastic and Reconstructive Surgery, and I will be presenting this combined clinical rounds on a case of an 8-month-old male child with a rare facial cleft. My patient, an 8-month-old male child resident of Bharatpur, presented to us with chief complaints of unusual shape and symmetry of face since birth, inability to suck while breastfeeding, and frequent episodes of cough and cold. My patient was born with mid-face deformity, which was getting evident over increasing age. Since he had difficulty in breastfeeding, he had history of taking top feeds with the help of a dropper till 2.5 months, followed by feeding with feeding bottles with modified nipples. There were 1 to 2 episodes of common cold every month, along with sneezing, watering of eyes, irritability, and difficulty in sleep, which was sometimes associated with fever or dry cough, which got relieved by treatment on OPD basis, and there was no history of any hospital admission during last 8 months since birth. There was no difficulty in breathing, no history of any high-grade fever or ear discharge, no history of any delayed milestones or abnormal movements. My patient was a first-born male child in family, born at full term through normal vaginal delivery in a primary healthcare facility with a birth. My patient was a first-born male child in family, born at full term through normal vaginal delivery in a primary healthcare facility with a birth weight of 3.5 kg. His developmental milestones were achieved as per his age, except for speech for obvious reasons. There was normal bowel and bladder habits with normal sleep and appetite. His immunization status was complete as per his age, and he is now due for MR vaccine next month. Perinatal history was, mother was primary gravida, and age of mother at conception was 21 years. There was no history of any consanguinity, and she had history of 3 antenatal visits. Ultrasonography for fetal well-being was done at each of her visits at 3 and 6 months of gestation and 1 week before expected date of delivery elsewhere in her native village, and no abnormality was detected in either of the scans. There was no history of any infection like fever during all 3 trimesters, and no history of any addiction or teratogenic drug intake or radiation exposure to mother in any of the trimesters. So as per the pedigree chart, the child was the first born affected male child in the family in 3 generations. Patient was examined in a well-lit room on an examination table. He was conscious and active with good cry, with stable vitals. Pulse was 110 beats per minute, regular in rate, rhythm and volume with no radioradial and radiofemoral delay. BP was 98/56 millimeters of mercury. SpO2 was 99% on room air, and respiratory rate was 30 breaths per minute.
with no evidence of any pallor, cyanosis, icterus, clubbing, edema, lymphadenopathy. His anthropometric measurements were all within normal limits and above 50th centile. On local examination, on inspection, there was flattening of forehead present with widening of glabella and root of nose, wide spaced eyes, slanting of right eye, deformed tip of nose, deviated nasal septum was also there, with absent nasal sill and floor and bilateral cleft lip. There was cleft palate, superiorly displaced premaxilla, visible nasal turbinates, visible alveolus on bilaterally, lateral part of upper lip present bilaterally, normal lower lip and tongue, and scab was noted over premaxilla, which was possibly due to frictions with clothes while in lab, probably. Normal shape of head and hair growth was noted with normal ears bilaterally. On palpation, temperature was normal and all findings on inspection was confirmed, and in distance between the two medial canthus was measured, which was 64 millimeters, and the normal range of intercanthal distance at this age group is 28.3 to 29.2 millimeters. And interorbital distance, although it is a bony measurement, was 53 millimeters in my patient, and for this age group the normal values is between 15 to 20 millimeters. Other systemic examinations were all within normal limits. So based on history and clinical examination, now I would like to ask the audience, what can be the provisional diagnosis for this patient? Anyone from the audience? Okay. So I summarize my history and local examination. An 8-month-old full-term normally vaginal delivered male child with history of facial dysmorphism since birth and difficulty in breastfeeding, and on local examination, deformed nasal shape and symmetry with increased interorbital distance and presence of bilateral cleft lip and palate. My provisional diagnosis is, for this patient, will be congenital facial cleft deformity. For confirmation of my diagnosis, I would like to subject the patient for further investigations, and for this 3D CT scan was performed, CT face with 3D reconstruction, and for further elaboration I would like to invite Dr. Aditya from the Department of Radiodiagnosis. Please, Dr. Aditya.
Good morning, respected dignitaries, faculty, seniors and colleagues. Today I will be presenting the radiological finding of this case. So these are the pre-operative imaging of the 3D CT scan of the face, in which we can see there is a, so here we can see there is a wide cleft is seen between the bony orbits, maxillary bones, and the ethmoid elements are seen posteriorly to the sphenoid bone. There is an increase in the interorbital distance between the bony orbits, which is the suggestive of that there is a hypertelorism in this case. Now, the maxillary bones, basically the maxillary bones appear separated with the interspace bridged by the ethmoid bone, and the premaxillary bone, here we can see the premaxillary bone is separated, and we can see there is a median bar of bone which is seen extended anteriorly and is communicating to the midline nasal septum in the midline cavity. So these are the axial sagittal section of the bone window, in which we can see the same finding. There is a cleft which we can see in the maxilla, and we can see that there is a premaxillary cleft and the median bar of bone which is seen extended anteriorly, and it is communicating to the midline by in the midline to the nasal cavity. So the above features are suggestive of the median cleft facial syndrome and bilateral hypertelorism. There is a median There is a median cleft nose, upper lip, palate and maxilla. Thank you very much. Now I call Dr. Supriya for continuing the presentation.
Thank you, Dr. Aditya. Thank you, Dr. Aditya. So, based on history, local examination and the radiological investigations, we have come the radiological investigations which was suggestive of the cranial extension of the cleft. The cleft was there in the face and also extending cranially. So, the final diagnosis for my patient is a congenital craniofacial cleft. Before going to details, I would like to tell that this type of craniofacial clefts are very rare and the incidence being 1.4 to 4.9 per 1 lakh live births. And Paul Tessier, a very famous French plastic surgeon in 1976, classified these cranial clefts into based on their anatomic location and numbered them from 0 to 14. And the facial clefts were numbered between 0 to 7 and the cranial clefts were numbered between 8 to 14. So my patient lies in the category Tessier cleft type 1 and 13, which is not exactly median, it's a paramedian cleft. So my final diagnosis is congenital Tessier cleft type 1 and 13 cleft deformity. So now we are coming to our management part. What is our aim and how we formulated our surgical plan? That is the first thing I would like to discuss. And for aims, our aim was to provide normal lip and palate so that child can eat and speak properly, to bring eyes at normal distance for binocular vision, and to provide a normal nose and improve facial aesthetics. And for this, I would like to describe the surgical plan we made for the patient. And it was correction of the facial deformity, correction of medialization, hypertelorism by medialization of orbits, and repair of bilateral cleft lip. Our plan was sequential and it was stage-wise surgery was planned. So in the first stage, we were going to do these three things. That was correction of cleft along with correction of hypertelorism and bilateral cleft lip, followed by palatoplasty, that is repair of cleft palate in the second stage, and followed by corrective rhinoplasty for correction of distorted nasal shape and symmetry. For this, patient was subjected to routine investigations and those were grossly within normal limits. Chest X-ray was performed which was of normal study. 2D echocardiography was performed to rule out any congenital cardiac abnormality, but it was also normal. And since the child was an anticipated difficult incubation due to his distorted nasal anatomy, there were anesthetic challenges, and for this part I would like to invite Dr. Shubhangi from Department of Anesthesia for further elaboration and its management part. Thank you.
Thank you, Dr. Supriya. A very good morning to respected teachers, seniors and my dear colleagues. I am Dr. Shubhangi Agrawal from the Department of Anesthesia and I am here to take the discussion forward regarding the anesthetic challenges of this case. Now, what are the challenges that this case presents to us? Firstly, there is going to be difficult bag and mask ventilation, and secondly, difficult laryngoscopy. The major anesthetic considerations of this case are airway challenges of the disease due to distorted airway anatomy, facial dysmorphism, shared airway. Now, what is a shared airway? When the surgeon and the anesthetist share the same space, that is a shared airway. Now, what is the problem associated with it? It presents to us with the possibility of inadvertent extubation during the procedure, major anticipated blood loss and difficult IV access. Now, summarizing the case, an 8-month-old male child presented to us in the pre-anesthetic checkup with the diagnosis of craniofacial deformity. Now, what did we look for in the history? There was no history of respiratory tract infections. Now, why is it important for us? Because any respiratory tract infection renders the airway hyperreactive, and this can present to us intraoperatively with bronchospasm. There were no associated congenital heart diseases or any multi-system involvement as discussed before. The general and systemic examination were normal. Here what is important for us was the airway examination. The external examination showed us a median cleft face with cleft nose, upper lip, maxilla and palate. Mandible appeared to be normal, jaw movement was adequate. Malampatti class here could not be assessed because for assessing Malampatti class we need the palate, and this patient, as we can see, had a cleft palate. The investigations were within normal limits. Now, why was this a difficult airway? Firstly, the most important challenge here was difficult bag and mask ventilation. Now, for a normal face mask ventilation, you need a proper seal. A seal that covers your mouth, nose and chin, but not the eyes. And as is evident in this picture, the patient has a distorted nose. So what we did to overcome this challenge, we used an adult-sized face mask and we kept oropharyngeal airways ready. Now the second challenge that this patient throws us is difficult laryngoscopy. Now why is the laryngoscopy difficult here? Because while doing scopy, the blade needs stability. The stability is basically provided by the palate. And here, since due to the absence of palate, the laryngoscope blade would be rendered highly unstable. And in addition to that, there were additional problems that are related to any pediatric airway like large head, higher up larynx, floppy epiglottis and subglottic narrowing. The parents were also counseled regarding the difficulties associated with the airway and our plan of action. So what was our plan of action for difficult laryngoscopy and intubation? We first proceeded, our plan A was to proceed with direct laryngoscopy and move ahead with tracheal intubation. Now due to the expertise of our consultants, we were able to achieve plan A successfully. Now what would have happened had this plan failed? Then we would have gone for a supraglottic airway device. Now what is a supraglottic airway device? As is evident by the name, this device rests right above the glottis. Now this is not a definite airway. You cannot conduct the surgery using a supraglottic airway device. You would ultimately need tracheal intubation. So what would we do to achieve that? We would do a fiber optic tracheal intubation through the supraglottic airway device as is shown by the picture on the left side. Now, what would we do if even this failed? Then we would have had to awaken the patient and reschedule the surgery because definitive airway is not provided here. Now, what would have happened if our supraglottic airway device would have failed? Then we would have had to revert to face mask ventilation to oxygenate the patient. What if this failed? Then that is the most dire situation in an anesthesia. We would have had to go for a front of neck access using either cricothyroidotomy or a tracheostomy. So keeping all this in mind, this is how we prepared our airway card for the anticipated difficult airway. We kept adult and pediatric sized face masks, oropharyngeal airways, laryngeal mask airways, Miller's and McIntosh blades, endotracheal tubes, both cuffed and uncuffed, tracheostomy tubes, pediatric fiber optic, video laryngoscope, and throat bags. Now, intraoperative monitoring included ECG, saturation, EtCO2, NIBP, temperature monitoring, invasive blood pressure monitoring, CVP, and urine output. Now, coming to the intraoperative management. Induction of this patient was done using number 3 face mask. Now, emphasizing this point here. The picture on the right hand side is size 0 face mask, which we would have used in this patient had this patient had a normal anatomy, but we went for a size 3 mask, which is the mask on the immediate left side. Coming to the laryngoscopy, a size 4 flexometallic tube was used. And why did we use flexometallic? What is the importance of flexometallic tube here? As is seen in this picture, even after so much bending and twisting, it does not kink. And it is very important in this case because the surgeon would maneuver the head frequently, and we need to prevent kinking to prevent any airway obstruction. So again, another important part here is fixing the tube. We fixed it in midline over the chin to safeguard the tube. Again, because of multiple handling of frequent handling of the head, the tube might get extubated. Throat pack was placed to secure the position of the tube. 222 gauge cannulas were secured. Left femoral artery was cannulated for invasive blood pressure monitoring. Right internal jugular vein was cannulated for central venous access. Now this is a video showing the laryngoscopy and tracheal intubation. We can see how unstable the laryngoscope here is. Now, what were the problems encountered inoperatively? Possibility of inadvertent extubation during the procedure. Now, what did we do to prevent it? Whenever the surgeon would handle the head, we were informed and we made sure that we held the tube and stabilized it. And we also used capnography. Now, any inadvertent extubation would immediately alert to us by a sudden drop of EtCO2. Now, due to anticipated high blood loss, blood products were arranged preoperatively and 450 ml, that is 3 units of PRBCs, were transfused intraoperatively, which was around 70% of the blood volume. Invasive blood pressure monitoring was done to avoid hypothermia. Core temperature monitoring was done and warmers were used. Bone-directed fluid therapy was done. 4 mics per kg of fentanyl in intermittent doses and 130 milligrams of paracetamol were used to ensure analgesia. ABG and RBS monitorings were done. Duration of the surgery were 5 hours. Now, we made the decision to shift this patient intubated for elective ventilation. Why was this decision taken? Because due to extensive airway edema post-operatively and oozing from the surgical site. If we had taken the decision to extubate this patient, there would have been airway obstruction and chances of aspiration. And then securing the airway here would have been very difficult. So patient was shifted to PICU intubated. Tube care was done using throat pack to stabilize the tube, and tube was refixed at the angle of mouth. This was the ABG at the time of shifting the patient to PICU. Hemoglobin was stabilized at 15. pH was 7.352. Now I would like to hand over the mic to Dr. Sakshi from the Department of Pediatrics.
So now, as per the surgical plan, the first stage surgery was correction of facial deformity along with correction of bilateral cleft lip. Facial bipartition with bilateral cleft lip repair was planned. What is facial bipartition? Actually, it is a surgical procedure initially proposed by Van Mullen and described by Paul Tessier, in which we perform en-bloc medial mobilization of both orbits and maxilla together in order to correct the abnormal forehead shape, correction of increased interorbital distance and reduction of width of cleft palate. So for this, we started with, after paint and drape, bicoronal incision was given and skin flaps were raised till supraorbital ridge. Then after periosteal stripping, the temporalis muscle was raised to reach up to the lateral wall of orbit. Frontal craniotomy was then performed and it was followed by dissection of orbital contents laterally, superiorly and medially without detaching medial canthus. There is a small video of dissection of orbital contents by preserving the orbital contents with the help of the malleable retractor. Here we are working on the lateral wall of the orbit and preserving the orbital contents with the malleable retractor. Zygoma and lateral wall of orbit are cut, and this mid-face part, the orbit is made free from roof of the orbit, the lateral wall and the medial wall of orbit. The purpose is to let it be free, and then so that we can mobilize it medially together. By gentle manual compression, the dura is preserved and the orbit is made free from roof, superiorly from the roof. So with careful dissection of dura, roof of orbit and medial wall then cut, maxilla then separated from pterygomaxillary plate, and both orbital segments are then brought together in midline and is fused and is fixed with steel wires. Replaced bone fragments were then replaced and fixed with stainless steel wires. This was followed by the correction of nasal deformity, in which the same setting, sir. The prolabium and premaxilla was brought in midline and was fixed in midline, sutured in midline, followed by correction of bilateral cleft lip. And these were the images of the closure of suture lines. So post-operatively, patient was then shifted to PICU in intubated state with a throat pack in situ under anticonvulsant prophylaxis and with antibiotic coverage. And now I would like to request Dr. Sakshi to discuss about the PICU stay of the patient.
Thank you, boss. Good morning, Honorable Chairperson, sir, respected faculty members and fellow residents. I am Dr. Sakshi Agarwal, resident of Pediatrics, going to talk about PICU management of the patient. We received 8-month-old male child weighing 8.5 kgs who was operated for facial bipartition with bilateral cleft lip repair under general anesthesia in PICU. When received, the child was intubated and was not on any inotropic support. He was normothermic and child was having one central venous line, urinary catheter and one arterial line in situ. After receiving child in PICU, he was taken on SIMV BC mode of ventilation and IV antibiotic and injection levetiracetam was continued. Serial ABGs were done in which PCO2 was maintained, lactate was normal and it showed respiratory improvement, thus ventilatory settings were weaned off accordingly. We faced certain difficulties while managing patient in PICU. There was significant blood loss for which massive blood transfusion was done during surgery. Fluid replacement was also initiated. We anticipated difficulty while extubating the patient as there was severe facial edema for which injection methylprednisolone was given in pulse dose. And child was continued on ventilatory support for next 48 hours. As child was hemodynamically and respiratory-wise stable on ventilation for initial 48 hours, CPAP trial was given on post-op day 3 and child was extubated and taken on HFNC with NRM mask. The most difficult part to manage this child in PICU was post-extubation respiratory support as there was not fully formed nasal nostrils to use nasal cannula and there was also significant edema present in oral cavity due to surgical procedures. And so, HFNC was used using a large size nasal cannula which was placed in oral cavity and NRM mask was used to give to provide high peak and high FiO2 in this patient. As child was maintaining saturation, HFNC settings were weaned off and child was taken on room air by post-op day 7. Child also had fever spikes of on post-op day 2, maximum noted temperature being 101, which suggested the possibility of systemic inflammatory response syndrome or sepsis. Antibiotics were continued and septic workup was sent, which reported to be within normal limits and all cultures were sterile. Fever got settled in next 48 hours. Child was also started on orogastric feed 5 ml every 3 hourly by post-op day 4, which was gradually increased to full feeds. By the end of PICU stay, child was accepting feeds by dropper. As child was hemodynamically stable and maintaining saturation on room air, he was shifted back to plastic surgery ward. Thank you. Now I would like to call upon Dr. Aditya.
Now we can see there are the post-operative changes are seen in the visualized skull bone. In first image we can see there is the repair of the cleft lip with post-operative positioning of the median bar of the bone, which was seen extended anteriorly and to the left in the previous scan. So this is the axial view of the CT skull base. So these are the anthropometric measurement which help us to determine the craniofacial deformity. So the first is the interorbital distance, which is the distance between the two dacrya. Second one is the intercanthal distance, which is the distance between the two medial cantha of the eye. And third one is the distance between the lateral wall of the intraorbital distance, which is the distance between the two zygoma. In this second image, we can see that the intraorbital distance was 35 mm, which was preoperatively, and it was reduced to 20 mm post-operatively, which shows there is a decrease in the interorbital distance, which was basically seen after the post-operative status. Thank you very much. Now I call Dr. Supriya to complete the presentation.
Thank you, Dr. Aditya. So now I'd like to show some comparative photographs of pre-operative and post-operative stages of the patient. The first, this is the image showing the pre-operatively the intercanthal distance was 64 millimeters, which has now become 37 millimeters post-operatively. These are another pre and post-operative images of the patient during surgery. So our further surgical plan, what is our further surgical plan? As explained earlier, after 3 months of first surgery, patient will be subjected for another surgery, and that will be repair of cleft palate, that is palatoplasty, and correction of nasal deformity in a further stage at 3 to 4 years of age before the child starts going to school. And further, if required, corrective rhinoplasty when the skeletal maturity is achieved at 14 to 16 years of age. Now the discussion part. So craniofacial clefts, as we have discussed earlier, that these are rare clefts with an incidence of 1.4 to 4.9 per 1 lakh live births. These can exist unilaterally or bilaterally and are of these sporadic occurrence. Not of much literature is there regarding the syndromic association except for Teicher 5 and 8, which usually have association with Treacher-Collins syndrome, that is the mandibulofacial dysostosis, and Goldenhar, which is hemifacial microsomia. The Treacher-Collins I can rule out by my clinical examination that mandible is normal in my patient and head shape is normal, so Goldenhar is also ruled out. There is no microsomia in my patient. As per the Teicher classification, the classical classification based upon the numbering, the classification, Teicher classification is now further elaborated as into subgroups, and there are 4 subgroups. These are midline, paramedian, orbital and lateral clefts. So Teicher type 3 is the most common type, and not much literature is there regarding Teicher type 1 cleft deformity. It is a paramedian type cleft deformity. Van der Meulen nominated it as type 3 nasoschisis nasal dysplasia, and incidence is 0.24% of all facial clefts. It can present in the form of a small notch in paramedian location also. So extent, it passes through Cupid's bow and then alar cartilage dome. It separates nasal floor and extends posteriorly as cleft palate of hardens of palate. Extends in cephalad direction through junction of nasal bone and frontal process of maxilla, and with cranial extension present as number 13 cleft. I want to mention here that the simultaneous occurrence of type 1 and type 13 cleft in our case was of much rarer incidence and even not mentioned anywhere in literature. And I would like to show interesting case series is there of type 1 to 13 atypical craniofacial clefts. This is the recent literature available online. How do craniofacial clefts, how do facial clefts develop? For this, I would like to tell briefly about the embryology of face. So phase usually develops between the 4 to 8 weeks of intrauterine life, and it is formed by 5 processes. 1 is unpaired and 2 are paired processes. The unpaired process is frontonasal process, which is the downward projection of the mesenchyme covering forebrain. And the 2 paired processes are mandibular and maxillary process derived from first pharyngeal arch. So during intrauterine life, there occurs 2 theories are there of facial cleft, for facial clefting, and those are either failure of fusion or mesodermal penetration. So any arrest during the migration of these mesodermal migration results to failure of fusion of these processes and ultimately result to formation of cleft. So
the Department of Anatomy here for the embryology.
Sir,
CCR committee should have included Department of Anatomy. Why should they refuse? There is no reason to refuse.
the mandibular processes fuse in midline to form lower lip and part of lower jaw, and the maxillary and lateral nasal process form part of upper lip and lateral part of nose. The frontonasal process over time narrows and form part of central part of nose, and the maxillary processes fuse together to form part of philtrum. So till now we have discussed about the craniofacial cleft, about the embryology part, and now what is the standard modality of treatment for these clefts. So as per the literature, recent literature and the articles published in various reputed plastic surgery journals, facial bipartition is the standard modality of treatment, which we have performed in our patient.
This is for informational purposes.
Now I would like to request our respected Dr. G.S. Kalra sir to enlighten the audience with his golden words and his wonderful experience. And I must finish by acknowledging the patient and parents, hospital management, CCR committee, and my fellow colleagues from anesthesia, pediatrics and radiology. So,
I would like to make a brief comment before Professor Kalra takes on. One is it's commendable for both the anesthesia team and plastic surgery team. It is not that simple as it might have appeared to everyone. One question to Professor Kalra: how did you prevent cribriform plate injury? Because ethmoids are also separated.
The cribriform plate was removed.
Okay, so the next question which was going to be: did you take any precaution to prevent micro CSF leak through olfactory nerve foramina?
No, what we did was, basically in all these cases, wherever we want to medialize the orbit, we have to remove ethmoid. Because the ethmoid, if you must have seen, was very hypertrophied. Unless we remove that, it is technically not possible to bring together. So basically we remove ethmoid, and up to the level of the orbital roof, we need clearance. And at that point, we see dura under microscope, there has to be no leak. We specifically didn't see that we are going to remove cribriform plate. We basically remove ethmoid.
So fovea ethmoidalis is removed, cribriform plate is preserved as
yes.
Yeah. Then chances are minimal.
Yes.
Thank you.
Like here, the rare craniofacial clefts are itself rare. So it is very difficult for any surgeon to have a large series. But fortunately, working over the period of 30 years, I have, if we combined craniosynostosis and clefts, there are more than 500 cases. The series of more than 500 cases. More than around 250 cases of craniofacial cleft only. Even if we see a midline encephalocele, it is also a cleft primarily. It is a 14 cleft. So everything is treatable. That's the basic take-home message. With the help of everybody, all the attached people, management, and the hospital facilities, that's very important. And I'm here specifically to thank Dr. Shankar and all the team of anesthesia and pediatric who took over all that, who were sensitized very much. And this is one of the rare cases, so they have to work very hard. And the girl who presented here, she really worked very hard in the post-operative pediatric.
But she or you or your department present this case again after second surgery and maybe after, especially after second surgery, correction of the
Thank you.
left leg.